I want to thank everybody for joining us. This is the fourth in a series of 4 interactive sessions that we've been holding, building upon some work that Dr. Denny Cortese from Arizona State University and former CEO of Mayo Clinic has been leading with others with 8 different healthcare systems in the Maricopa area. And we'll go through some of that in just a moment. What I'd like to do, just for the structure of this particular session, what we will do is we'll do some introductions. We have 2 very distinguished guests with us to start the conversation. But a reminder that this is really designed to be an interactive discussion. We've had a lot of engagement in the others, and it really is the participation of this broad and multidisciplinary community that is going to help inform a white paper related to how we can create a more secure health system. So I'd like to turn it over, and then I'll tell you a little bit more about the presentation and the work that Dr. Cortese has been leading. Give you a little bit of insight, if you weren't able to join us, to some of the discussions in the prior interactive sessions. And we'll explore a little bit the fact that we've been looking at these strategic pillars in a little bit in silos. But as we know, there are always interdependencies across the system. And sometimes it's when we forget those or don't understand some of them that some of the most well-intended efforts can fall flat or run into unintended consequences. Perhaps most importantly, we will be exploring some of these sustainable models that will drive more systemic collaboration so we can take the lessons learned so that we don't suffer amnesia again. And suddenly, if we're facing another pandemic or critical emergency, we're starting from scratch, that we have actually built upon the lessons. And as I said, this is really designed to be an open dialogue. And so I'm going to turn this over to Anna Choi now, who is going to give you some instruction in terms of how you can engage in the conversation.
Hi, welcome. Thank you for attending. I'm just going to do a quick housekeeping rule. So because this is an interactive session, we do ask that you either ask your questions via the chat or raising your hand. So one of the ways is with chat. On your bottom screen, you'll see a little chat icon, and you can just click there, write your questions, and someone will either say it out loud and ask the question. Another way is to raise your hand, and it's on the bottom screen. You can either go to your reactions icon, and there you'll see a raise hand. The other way to raise your hand is go to the participants icon, which is a little bit to the left, and find your name, and you can see the hand sign there as well. When you raise your hand, again, someone will just call your name, and you can turn on your video or just turn on your mic and ask your questions. If we can't answer your questions, we will send a follow-up email with the answers. If you have any other questions or concerns, just email me. My email is right below. Thank you.
Thank you very much, Anna. And if you do have questions, of course, enter them. Questions, whether it's a technical or a logistical question, or a question you'd like to ask, or a comment as well, because we are also, the comments that we're receiving in the chat are also going to be considered for informing the white paper that we are preparing at the end of this. And a reminder, there will be an evaluation at the end. It will be posted in the chat. You'll see a follow-up email as well. And we encourage you to do that because if you fill out the evaluation, we also will make sure that you receive a copy of the final white paper. As I mentioned, we have 2 very distinguished guests with us today. I'd like to introduce them to you now, and then I'll go back and tell you a little bit more about the McKenna Lecture Series and the work that we have done to date, just so that we're not interrupting the flow. Dr. Jeffrey Gold is the Chancellor of the University of Nebraska Medical Center. He was named the Chancellor of the University of Nebraska Medical Center back in 2014, and 3 years later, he was also named Chancellor of the University of Nebraska at Omaha. You may know that the University Medical Center is also home to the Global Center for Health Security. That houses the internationally acclaimed Nebraska Biocontainment Unit, which has set the global gold standard for safely treating special pathogens during the Ebola crisis. The center also received some of the very early COVID patients that were being returned from Wuhan province in China, as well as some of the patients that were and the individuals who were on cruise ships where the infection had also broken out. Dr. Gold is highly respected and a very active leader in our nation's work to strengthen our ability to respond effectively and securely to disasters. That brief introduction does not, fully inform you of all the work that Dr. Gold is doing, and so I hope that he will share some of that in his open commentary. Our other distinguished speaker and conversation starter, because we said this is an opportunity for everybody to engage. Dr. Duane Kaniva most recently served as Chief Medical Officer for the U.S. Department of Homeland Security. That role capped off 32 years of public service, including 2 separate details to the White House National Security Staff as Director of Medical Preparedness Policy under Presidents Bush, President Trump, and President Obama. Dr. Kaniva entered public service after a distinguished 23-year career in the U.S. Navy. His tours of duty included, among others, serving as Director of Emergency Preparedness on the staff of the Navy Surgeon General and deployment as head of the Shock Trauma Platoon in Fallujah, Iraq. And again, that very brief introduction does not share the full gamut of Dr. Kaniva's experience either. We look forward to and thank them for their participation today. I'd like to tell you just a little bit about how we got here. This is all part of the annual McKenna Health Policy Lecture. This was something we started over 10 years ago. It was started by the Health Sector Supply Chain Research Consortium, which was founded by Mark McKenna, who at the time was the president of Innovation, along with Professor Gene Schneller, who is a very active member of this group, but unfortunately has a conflict today and could not join us. But they formed the Health Sector Supply Chain Research Consortium, which is now a part of CAPS Research. CAPS Research is a public-private partnership between the Institute for Supply Management and Arizona State University. And we'll tell you a little bit more about CAPS Research shortly. But we have brought a number of luminaries to the Arizona State University campus, previously in person. This year, obviously, for obvious reasons, we are doing things virtually and hope to be back in person next year. But we bring leaders such as former CMS Administrator and FDA Commissioner Mark McClellan, former HH Secretary Mike Levitt, former ONC Coordinator David Blumenthal, a number of luminaries, Eric Topol, who does a significant amount of research, and you may most know him from his book, The Patient Will See You Now. So we're very, very proud of the quality of speakers that we have brought to this lecture series, and we do it at no charge. It is funded solely from donations to the Mark McKenna Lecture Endowment. And on your evaluation, you will also see an opportunity to offer a donation of any size will be greatly appreciated so that we can continue these very, very important discussions. So this started this year with a virtual lecture series presented by Dr. Denny Cortese, and it was titled Lessons from the Pandemic, Building a Secure Healthcare System. And if you weren't able to join us for the lecture, we encourage you to check out the full recording, which is available on the CAPS Research website. As part of that lecture, Dr. Cortese discussed some work that he is doing with others with 8 Phoenix area delivery organizations of all types and sizes. You have some very, very large systems like Common Spirit Health, Mayo Clinic, Banner Health, et cetera. You have smaller organizations like Phoenix Children's the hospital associated with the U.S. Department of Veterans Affairs, and a county hospital. So really a wide range of organizations, and started with the work with the CEOs. And you can see here what the vision statement is. And working with those CEOs, they started to identify work that needed to be done internally and locally among those delivery systems. But there was also a need to work at the public health system level. Both very important parts of our healthcare system, but also very different. And as we have experienced during the pandemic, not always well coordinated. So that's one of the important discussions that we are having as a result of this. The CEOs identified 3 strategic pillars. And so each of the prior interactive sessions that we have held on the prior Thursday since the lecture addressed issues of infrastructure and facilities, healthy workforce, and matching supply and demand. And while we were looking at them, as the focus areas, every single conversation brought up different kinds of, interdependencies, and there were common themes. And so we want to discuss a little bit about that. But perhaps most importantly is, if we're going to continue this work going forward, what is that framework? What is that structure? What is that model that allows us to sustain this level of collaboration to help and secure that we are able to respond more effectively, more quickly to future emergencies, disasters, pandemics, et cetera, and at the same time, is there a model that also helps us continue to deliver quality care, effective care in normal times as well as in extraordinary times? So for those, there is no way that I can do justice in a short period of time to some of the themes and the richness of the discussion that will be covered in the white paper. But I thought it was interesting as I was looking back at my notes and at the transcripts from the sessions, some of the key themes that came out, and there are some common themes. So in the infrastructure and facilities discussion, we looked at and discussed this 60% increase in the use of virtual care, and really this idea of virtual care across a continuum and across a level of intensity. So everything from a doctor's visit to a panel of intensivists who are able to virtually care for patients who are in ICUs, or even caring for patients that are quarantined, contained at home, but having those standards, understanding what to look for, and perhaps, knowing when they would need to come into a medical center. And then we discussed the buildings, et cetera. Can you set up parking garages to, suddenly become containment areas? Can we make all rooms easily convertible to an ICU? So you have this concept of flexibility in space in this particular area. And we looked at some of the things underneath, the air scrubbing, the putting UV lights on, what is the standard for air scrubbing so that people are comfortable. When there are standards, people feel like, okay, somebody has looked at this, there's science behind it, et cetera. It's not just because somebody in my institution told me it was okay, which is the same kind of situation that we faced with in terms of different kinds of conservation measures for personal protective equipment, for example. We have to think about the appropriate and the safe movement of people, of products, of data, and there are certifications and credentialing that come along with that. As we moved into discussions about the healthy workforce, and certainly the desire, as Dr. Marjorie Bessel, who is the Chief Clinical Officer from Banner Health, talked about it, our primary purpose, save as many lives as possible. And that means protecting the practitioners as well as protecting the patients. But when we talked a lot about supply shortages, such as PPE, but the issue was one of our most critical, if not the most critical shortage, was in trained staff. So how do you move perhaps practitioners across state lines when you're running across issues regarding different kinds of credentialing practices? What about training people so we can upscale staff from an ambulatory setting to an acute care setting? A nurse who's normally working on the med-surg floor now is working in the ICU. Could we be using virtual care to be training and helping those staff that may not have as much experience? Can we be helping them on the ground, particularly in very, very rural and remote areas? Interesting discussion about things like physician assistants that are trained in a manner that enables them to work in primary care, or more and more they're working in specialized medicine as well. And then communication is critical through all of this. In the conversation last week on matching supply and demand, one of the most interesting conversations I thought was how Banner Health had decided when they could not get the isolation gowns, they went out to local companies, local fabricators, worked with clinicians, designed their own spec, and created reusable isolation gowns that the clinicians have great confidence in because they helped design it. And so they're continuing to use those gowns, whereas what we're seeing in other communities where once the disposable gowns came back, there are a number of clinicians who are saying, no, I want to go back to what we used to use because they're more comfortable with it. We had an interesting conversation. It was actually in the very first one, but it's a supply chain issue, as is many of this, is around the testing supply chain. Issues related to certification for testing sites, the availability of control specimens, and what you would call the cold chain for specimen collection, and some of the challenges when you're collecting specimens in the middle of summer in Arizona. How do you maintain that molecular integrity of those specimens, sending them to the testing site? Similar issues that we faced, obviously, with the vaccine as well. And then there are always dependencies, just because you might have enough ventilators, people started running out of or getting low on oxygen or the HEPA filters, et cetera. And we had an interesting discussion about the Civica RX model, which is where a number of providers have come together, formed a not-for-profit organization, and are working with suppliers to ensure supply of generic pharmaceuticals. But now BARDA is actually investing in building domestic manufacturing sites. So as I looked at some of these things, you look at this issue of standards. These are standards, the mechanical, electrical, plumbing standards, but what are the standards for training? What are the standards when you suddenly have to have emergency authorization to allow somebody who is licensed in one state to work in the other state? These are not things to figure out in the middle of a crisis. These are things to think about and do simulations with multiple disciplines sitting around the table ahead of time, because every clinician on this call understands that criticality of time. Seconds matter when you're facing a crisis. And then how do we handle effective resource management? What I would view as really a supply chain, and this is from the design of products, from the identification of need and design for purpose to delivery of those products, but also the people trained to use those products and the data around the patients and the efficacy, the evidence related to the different types of care we're delivering. So I mentioned the concept of how do we prevent that collective amnesia. And we were really, really smart back in 2015. I'm sure a number of you have seen the quote from Bill Gates from the New England Journal of Medicine. I also pulled up a couple of pieces recently, one from the World Economic Forum, and this was specifically related to lessons learned from Ebola. And you can see, and I know that Dr. Gold has had, the Global Center for Health Security, has had significant experience in the Ebola crisis. But one of the things that came to light was, what can the private sector do better than the public sector? But how do we get past this lack of trust, which is one of the issues, and I think Dr. Cortese can speak to this, that has been an issue that those involved in the Maricopa County effort have been dealing with. And just simply because I think it's Infrastructure Week, and we certainly had a lot of discussion about infrastructure in the news yesterday following the proposal by the Biden administration. This is actually a study that was done by the Boston Consulting Group, and it was focused more on handling disasters in Pakistan, Madagascar, and Chad. But I think the lessons carry over in any kind of emergency. But I'd be curious of what Drs. Gold and Kneva think. But what was interesting is they looked at the ROI. They looked at the value of different things, such as infrastructure investment, having the highest savings, training, having the highest ROI. If you've got good coping capacity in a region, then the training becomes even more important. But you have these dependencies related. So I just set those up for, there's so much literature out there and so much discussion, but the key is implementation science. How do we make this, how do we take these lessons and structure our work going forward to create that more secure health system future? And with that, I would invite Dr. Gold to offer a few comments to get our conversation started.
Well, thank you so much for this opportunity. I was told I have to be brief and provocative, and I will try to be a bit of both. But first, a bit of an apology. For those of you that don't know me, I'm a nearly recovered cardiac surgeon from the East Coast who's been slowly moving west, and currently for the last 7 years, I've had the opportunity to serve as the chancellor here at the University of Nebraska Medical Center. And one of the centers of excellence is referred to as the Global Center for Health Security, which has been leaning in for many, many years, nearly 20 years, going back to the immediate post 9/11 days when we were talking about white powder in envelopes and SARS and other such things in the areas of biocontainment, isolation, quarantine, etc. Indeed, we are the only designated national center for quarantine and isolation, tightly partnered with the Department of Defense, Homeland Security, Health and Human Services, the Department of State, the VA, with the White House, and it goes through multiple administrations and obviously both sides of the aisle. I thought, given the very few minutes that I have with you, I think if there's a single message that I'd like to share is that a structure based on effective, trusting, public-private partnerships is probably the only sustainable, affordable, and high-impact solution to not having to go down the road again that we've been through in this pandemic. Indeed, I would say the only tragedy bigger than the one that we are currently living through on a day-to-day basis, and I don't just mean the medical impact of this, but the impact on our economy, the impact on the quality of lives, our spiritual lives, our families, etc., would be to not effectively learn and implement change as a result of this. So what I thought I would do very briefly is just read to you from a manuscript not authored by me, but authored by Don Berwick and Ken Shine before anybody ever knew what COVID-19 was. This was the result of a study group that was convened by the National Academy of Medicine and by ASPR, the Assistant Secretary for Preparedness and Response, to, quote, study enhancing private sector health system preparedness for 21st century threats. And so I will now quote to you. It starts off by saying, not since the threat of global nuclear war first emerged has humankind faced the risk of potential disasters at the scale of the 21st century threats now brings. they talk about all different types of conventional threats that deal everything from biological to chemical to radiation, nuclear, environmental, explosive, etc. types of threats on a national and international level. And they also talk about threats that deal with infrastructure failure, specifically what would happen if the water supply, the power grid, etc., were to go out in a regional area and there was either no national 21st century threat and it was just routine care that was interrupted, or if simultaneously we were dealing with a power failure and a chemical spill or a nuclear accident, etc., in the same geographic area. Indeed, the model that we spoke of for several, this went on for a year, by the way, on and off, was there are 28,500 American military in South Korea. If there was a nuclear or a biological or a chemical event that occurred in South Korea and we had to repatriate 10,000 American citizens back to the United States in 5 to 10 days, what capacity would exist to do that? And the answer, regrettably, was none. And that without engaging an effective partnership between the public sector and the private sector, and there were many of our largest medical centers involved in this discussion, the regulatory bodies, the Department of Defense, Veterans Affairs. I mean, this was really the alphabet soup of who's doing what to whom. And so before I take your questions, and I'm more than pleased to answer anything that you might put in front of me, I just want to quote to you from the conclusion of the work that went in and authored by Ken Shine. And by the way, this is the February 6th edition of JAMA, and I'll put the reference in the chat. And they say, and I quote, both the federal government and many localities in the United States have made substantial progress in preparing for some local forms of mass casualty events. However, at this point, again, this is all pre-pandemic, remember that. However, at this point, the US healthcare system is wholly unprepared for a wide range of 21st century threats. It lacks the will, coordinative mechanisms, habits of cooperation, governance agreements, and shared resource investments essential to preparedness. Progress will require unprecedented participation and contribution from an enormous range of stakeholders, including government, the nonprofit and private sectors, and professionals involved in nearly all facets of healthcare. Hospitals, health systems, government agencies will manage and share information before, during, and after disasters. The way this is done will need to change. Investments by both the public and private sectors will need to expand. The only way forward is making parallel progress towards both a national system and regionally focused projects and developing implementation, a recognized standard for excellence in preparedness at the facility and system level. So as a direct result of this, a number of regional experiments, pilot programs were established. The first two were at Massachusetts General Hospital and at our institution here in Omaha as part of a multi-state region. So we are Region 7, and we are responsible for all of this coordination, organization, et cetera, in Region 7. As you probably know, Maricopa County is Region 9, and that has also been stood up at this time as well. But these are federal dollars that flow through ASPR to build the coordination, supply chain, training, and other facility-related mechanisms necessary to create the effective public-private partnerships. As Karen said in the introduction, we have had the opportunity here to lean in now for over 20 years in these areas. It's been a privilege to work with our federal, state, and local partners in this area, and I would say we have done quite a bit to effectively build trust among and between the regional and national organizations to get this done. A good deal of it grew out of what's called NETEC, the National Emerging Special Pathogens Training and Education Center, which was created through federal funding immediately after the Ebola pandemic in 2014 and 2015. But it has truly developed a life of its own. So I'll stop at that point, Karen, answer any questions that you or others may have now, and I will be with you for the remainder of your program today. And I will put my contact information in the chat unless you've already provided it. More than pleased to provide, of course, the reference to the manuscript from which I read, access to our web materials. By the way, everything we produce is publicly available, as Denny knows, and you would just simply go to our website for it. And I'll put that in the chat as well. So thank you.
Thank you very much. And yes, thank you for the providing us with your contact information and with the reference as well. A very compelling statement or statements in that. And I think it begs the question, you know, that was written some time ago. And now if you consider what we've gone through, and I think Denny could speak to this as well, in terms of that need for, you said, a tested, trusted public-private partnership. And I think that probably that trust level has gone down even further. At least I believe that, and perhaps Dr. Cortese, you could provide a little bit more context to that. I mean, how do we build that kind, how do we have the trust to build that kind of system in partnership when people are fearful that, you know, it will change with every administration, that they could be subject to political whims, et cetera, right or wrong? I mean, what's the foundation? How do you create that trust so we can build together?
Well, if you're asking me, a lot of it is based on personal relationships. You know, just spending a lot of time in people's offices on the Hill, in the Pentagon, you know, in the Hubert Humphrey building and many other places in the Beltway. I mean, we're literally on a first name basis with the secretaries, assistant secretaries, undersecretaries of every one of these departments and agencies literally on a daily basis. And that does build trust, and it has spanned multiple. So whether it was working with Dr. Nikki Lurie or Dr. Bob Cadillac, you know, clearly from both sides of the aisle, who served as the Assistant Secretary for Preparedness Response. We work very closely with the Joint Chiefs and their chief medical officers. We work with DHA, Defense Health Agency. You know, again, we have a philosophical approach where the answer is yes. By the way, what's the question? Which typically does produce solid and enduring relationships. And again, the same thing is true regionally. You know, we have a very, very close relationship on the state levels in our 4-state region. You know, these trusting relationships are not built overnight, but they are critically important. And, you know, how do you sustain them, Karen? I think there are a lot of different ways, but one of the best ways to do it is to build it into the law. That is to say, federal law, you know, policy, regulation, et cetera. So NETEC, the National Emergent Special Pathogen Training and Education, is built into the regulation and policy funded by the United States Congress. So it's not going away.
I think what I'd like to do is, I mean, I think there's so many, there's a lot to dig into in that, and particularly as we start looking at, you know, how do you build structures at the local level, at the state level, at the regional level, and the national. But I think I'd like to switch to Dr. Kaniva, because I know you've been doing a significant amount of work. And remind everybody, please raise your hand, add something in the chat, ask questions. This is not just me asking questions. This is folks entering into this conversation, so we look forward to it. But I know, Dr. Kaniva, you've done a lot of work around this concept of a national health reliability organization and kind of what is the structure, you know, what's the role the government can play while we're optimizing the knowledge, the expertise, the ability to move faster at the private sector level. Perhaps you can offer some of your thoughts now.
Yeah, thanks, Karen. Thanks for this opportunity. And I'm going to struggle to be brief. I don't know if I'm capable of that at this point in my life anymore, but I'll do my best. And, you know, shout out to some of the people on. I see some very familiar names and people who have been partners working through this, developing this concept over the last 14 years or so. I'm going to talk about a parallel universe where a NERC, a National Health Reliability Corporation, already exists. We do have a NERC FERC construct in the energy sector. We have similar constructs in other critical sectors. In the energy sector, you have the Federal Energy Regulatory Commission that oversees the North American Electric Reliability Corporation. It follows high reliability organization principles, which is really an engineered construct, which is unfortunately, I think, something that's a little bit foreign for us in the health sector, and something that we could, even though we talk about a system of systems biologically all the time. We don't necessarily use those engineering principles to help us out. So imagine a NERC, the House of Medicine, $3.5 trillion critical sector that is essentially ungoverned. And when we talk about the public-private partnership, part of the problem is we do not have that, in my opinion, we don't have that private sector effectively organized and governing itself to be able to build that bridge, that that span of the public-private partnership. So instead of a House of Medicine, we've got all the bricks that we need in a pile in the yard. And I'm talking about the bricks that include things like medical device manufacturers, biotech companies, academia, healthcare organizations, the retail healthcare supplies, and not just in terms of the treatment facilities, that the 18 different types of treatment facilities. So we've got 5,600 hospitals, but we've got tens of thousands of these alternate treatment care facility types, the long-term care facilities, the skilled nursing facilities, and whatnot that are included in that. The National Academy of Medicine is another key brick. The Joint Commission, the biodefense industry, pharmaceuticals, information technology, other CMS based participants for the healthcare facilities. And basically all these are bricks in that House of Medicine that are not effectively constructed in a way to provide the good governance and situational awareness that we need. And then as part of this house, we would have, as the roof, if you will, the National Health Reliability Organization that is, it's the cover, and it helps to organize that house, that entity. It looks for better, faster, cheaper. Reliability looks at quality, accessibility, and affordability. Just like in the energy sector, keep the lights on, keep electricity affordable. Same thing here, good quality medicine that is accessible and affordable to all patients under blue sky days as well as black sky days. It does have in this parallel universe, this dedicated regional, national, 24/7 emergency operations centers that are constantly monitoring the data. And I'll talk a little bit more about where that, the digital exchange model, but where does that data come from and how do we protect it, secure it, keep it private, but still allow us to do the surveillance and situational awareness that we need. How do we keep this interoperable with other critical sectors? Development of HIDEs, health information digital exchanges, and self-enforcement with government oversight. So what is the NERC? The NERC is a 501c3 organization with 10,000 corporate members, maybe more. The energy sector has over 2,000 private corporations that constitute the membership of it. It's the private sector span for that public-private partnership bridge. It's empowered by Congress, just like in the energy sector, to establish industry standards in the health sector and the related industries. So as a standard-setting organization, it has responsibilities under ANSI, must meet and maintain those standards setting organization responsibilities, but it is given that authority by Congress. Participation is voluntary. You don't have to participate in it, but if you're not a member, you're not participating in the standards development process. And it not only establishes, but it enforces, reviews, and updates the health sector industry standards and sets the practices. And so instead of publishing things, this gives us formal structure to what we call a standard of care process in healthcare that really is a misnomer. It's not a standard. It really doesn't exist in a formal, structured way like other industries have it. It has appropriate regulatory oversight by federal, state, local, tribal, territorial governments, provides governance structure for that $3.5 trillion sector, and it integrates and identifies the interdependencies with the other 15 critical sectors in our modern day society. Basic organizing principles. It's a system of systems architecture, just like the body, just like communities. You know, the human body with its organs that become systems, and systems that become that organism, and that organism that becomes a member of the community. We have these overarching and growing layers of complexity that that need to be accounted for and addressed in this governance system. It has a forum. That's the kitchen table. The kitchen table is a round table. It's multidisciplinary. Doctors have one seat at this large round table that requires these multiple disciplines to figure out how to do the governance effectively to keep medicine of good quality, accessible and affordable. It has a portal, uses common enterprise knowledge management system. I'll talk a little bit more about that in just a second, but it's got to be Web 2.3, 4.0 enabled, with the Internet of Things and the semantic web, and all that has to be instituted into the way that we do our health information digital exchange. And then it measures performance. Always measuring whatever we do. We've got to measure the outcomes to the best that we can to make sure that we are doing things right, that our standards are appropriate and correct. So I talked about the components: a portal, a forum where the governance structure exists, a portal where the information, the data is exchanged, and then an academy where the innovation occurs. Right now, the innovation is done in the private sector largely, and in government and academics, but it's again, sort of not as effectively organized as it should be. And then when you have this portal, it allows you to do a matrixed approach to the information and the data that you have. That information, turning data to information, information to knowledge, knowledge to wisdom, and so some of the key dimensions, if you will, include such things as standards. It's established to empowered to establish standards for the industry. So you have this standards framework that exists. It has a planning framework, and I would call out Mark Keim's ADAPT system as an example of a comprehensive planning framework that is extensible not only within a critical sector, but reaching across the other critical sectors. The quality and outcome metrics as another framework, response and incident management. This has to be effective not just for blue skies, but for black sky days, just like the energy sector has. Energy sector is prepared for the winter storms in the northeast, the hurricanes in the southeast, or the earthquakes in the southwest. These are all predictable black sky days, and the NERC in the medical component has to account for those black sky days as well. Health information data exchanges, I think digital exchanges, we have these non-fungible tokens. I think we've got to understand the role of blockchain, holochain in these, and I look forward to hearing comments from the audience on how to do this. But we can have merits and merits. Merits, if you're a patient, your data has value in a marketplace. We need to establish these digital exchange marketplaces where that data can be monetized or valued. If I have a lot of medical problems, my data is probably worth more, and I can use it to exchange for maybe for health insurance or for medical care. Or merits, medical reliability information tokens, where as part of my continuing medical education or my credentialing licensing, I, as part of that workforce, that, 2-3 million personal workforce, I am doing the participating in the standards development and review process, and I earn merits for that count and accrue towards my my CME and credentialing requirements. And then last framework I'll mention and then stop talking is the resource management. We talked a lot about this supply logistics and the criticality of that. When I was still back at DHS, we looked at the counterfeit. Started with the N95 masks, and anything that is of value beyond commodity level is going to be counterfeited, and this becomes particularly critical in the health sector, obviously. But how do we account for those things of the supply chain logistics mismatch, as we saw in the pandemic, and then not just those kinds of supply resources, but response resources. In Irma, when Irma went through Florida, within 3 days, 72 hours, we had 60,000 lineman technicians in the energy sector, private sector lineman technicians flooding into Florida, all credentialed, all permitted under the signature of the governor, under the Emergency Act, allowed to come in and restring the cable to get the power back on. We had 4,000 NDMS participants in the health sector who were tapped out. After Irma, had there been another disaster, we had no national disaster medical system personnel left in the kitty to respond, to provide any kind of medical resources. So how does the energy sector have 60,000 lineman technicians with their own bucket trucks, their own equipment, pre-staged, organized, and coming in, getting the lights on, and the health sector has nothing comparable in the private sector when all of those resources are in effect private sector resources. So I'll stop there, and happy to take any questions or hear your comments. Thanks.
Karen, this is Denny.
Yes.
Yeah, this is really great. Two great examples here. And I'd like to, having lived through this for over 25 years myself, I just like to make a couple of comments. The first is the electrical analogy is an excellent one, but it shows some of the significant weaknesses that we have in the country. Number one, the electrical analogy is most people will not argue that electricity is a national security issue. People will argue that healthcare and a healthy workforce is a national security issue. As a matter of fact, I think by the actions of our government, they've demonstrated for real over and over again that other things they overshadow the idea of a healthy workforce way more than they're willing to admit. And they do it by demonstrating that we don't have a National Institute of Health that works on health. We don't have really a real commitment to try to improve the determinants of health. So there is that big difference between electricity and healthcare. Second is electricity is basically an open market, or it's a regulated utility model. Either one assumes that there's going to be competition, and that if there isn't competition and you're in a regulated utility, you get a monopoly, and then you are directed to accomplish certain goals. At least that's the theory. And because of that, in exchange for that utility monopoly, you will not be allowed to make a large margin. It's capped somewhere between 5 and 10%. Wouldn't we in healthcare be so happy to be allowed to make 5 to 10%, or be managed in such a way that the regulators pay us through their ridiculous fee-for-service model, pay us enough that we can make 4% margins out of Medicare, for instance, from the federal government. Huge difference in the serious nature of taking healthcare as a national security issue, the way things are behaved through Washington. INPO, I've been trying to get INPO involved in healthcare, INPO now, the Institute for National Power, Nuclear Power Operators, to demonstrate this idea of system of systems, process lean management, process engineering, all that sort of stuff for over 25 to 30 years right now. The delivery systems think I'm crazy. Not INPO. INPO thinks they're ready to rock and roll. They think we're crazy. Why? Because we are paid when people are sick. Why would we care? Why should we change? We're paid when people are sick. We have a terrible system, and nobody has been trying to change this. We tried through the Obama administration to change the way payments were made for value, to begin to at least put a linchpin to change this whole payment model so that the system of systems in healthcare will self-organize and start to produce value rather than what we produce right now, which is everybody's making money. Every stakeholder is making a ton of money. The other thing is in electricity, which I really love. I'm on a board of an electric company, by the way, that has the largest nuclear power plants in the United States, in Arizona here. The idea of having a national vision for electricity is accepted. It may not be the best, but at least we got the idea we need to have a vision. There is no vision for healthcare in our country, none whatsoever at a senior level. So there's a big deficit there. Therefore, I've worked at the National Academy for a long time, as Jeff knows. I'm not going back to Washington. I'm going to challenge you all to think about this. How do we make this work? And despite Washington. And here's the example. This is why we're doing our work here in Maricopa County. Here's why. Here's the example. What would have happened in Nebraska to Section 7 if each governor didn't agree with what the directives were coming out of the federal level? This is what happened in Arizona. We were told how to practice medicine. And the weak spot is the whole thing, we actually listened. We didn't have the guts to stand up to tell the guys to go take a hike. We're staying open. Our job is to take care of patients and care for them no matter what, just like a military operation. When you're running a mass unit, I was with the Marine Corps, you can't walk out and top your hands up like this, say time out. The bullets are flying, you got to take care of everybody. And that's partly, and frankly, we paid a huge price for this because we stopped the delivery system from doing testing. We stopped the delivery system for taking care of patients. We had thousands of physicians on vacation. And we talk about no workforce. So I really want to hear from the two of you now. How would Nebraska have responded if they did not have, Jeff, excellent relationships with the governor in Nebraska and others? How would that work? Because when I talked to Jeff about this, I said, Jeff, can we get Arizona into your region? Let's just sign up for Region 7 and ask for help here, because I've got delivery system CEOs right now that are sitting here talking. They are madder than hell. They don't even want to consider doing anything with public health or with the national government or the state government right at this point. We're working through it. I think we'll get there. But they're trying to just solve it for the best they can be prepared for the future. And that's going to be really tough. And they're trying to do a pretty good job at this. So please give me some thoughts on how all these other states that are out there that were ignored. Our Region 9, we were totally ignored. I don't even know who directs it here in Region 9, for instance. So, okay, I'll stop. I just gave you a download of what we've run into here and see what you all have to say.
Well, again, more than pleased to weigh in for a few minutes. First of all, it's been less than perfect since the very beginning. And I would be misleading you if I painted any different picture. I would say that the way that this has come together is based upon 1, science, 2, timeliness of communication, accuracy of communication, 3, transparency, and 4, trying to get people to realize to the best of their ability that when local public health, state departments of health and human services, and in this case, the university works together, that we can do better things, take better care of people, and by the way, protect the populations that we serve, which is really the grail in all of this. The faster we can revert to what I effectively call the new normal situation, the better everybody off is going to be economically, and retain their their lives that they can get. But I will tell you, I mean, we have a sort of a unique community in that, first of all, we've been doing this kind of thing for a long time. 2 decades is a long time. I go back to the Ebola days when individuals were repatriated and cared for with Ebola virus disease. In some parts of the country, the local communities went nuts and said, why you're doing this? Why are you bringing this disease to our community? How dare you do this? In our community, it was more like, it's God's work. Congratulations. I'm so proud to be part of the community. When that kind of attitude is pervasive across the public and private sector, everything from the governor to the legislature to the chambers of commerce and on and on and on, it's a lot easier to accomplish the kinds of things. And then finally, I would say, having millions of dollars of grant-funded resources to build the networks, hire the people, build the technology, convene the critical public and private partners together, frankly, goes a long way. I mean, there's no question this is a resource-driven process. So I'll stop at that point, Denny, and more than pleased to take any other questions.
Dr. Gold, this is Brad Doubling from the College of Health Solutions. Could you just extend that discussion a little bit in terms of building that research and evaluation portfolio that you have? What are some of the early steps to get everyone on board to see the value and engage in that kind of planning?
Well, in some regards, it's actually become an economic development process, because we are everything. I mean, we are not a policy think tank. I mean, for instance, if you were to compare us to the Hopkins Center of Excellence, we are not a policy think tank. We are very operationally oriented. So for instance, we published easily a dozen playbooks for higher ed, pre-K, K-12, meat packing, the court systems, et cetera, early on in the pandemic. Developed a large number of the both antigen, antibody, and PCR tests for COVID. Did a tremendous amount of work in training. For instance, we do all of the NDMS special pathogen training for the country here. We train the United States Air Force so-called CSTARS program in Air Mobility Command for training, and this has been going on for years. This is not something that developed, overnight. And so when, they needed to repatriate people from Wuhan City, or for instance, when they needed a team to go to the Diamond Princess, they just called us. I mean, it was literally a Friday night that I've got ASPR on one phone, Department of State on the other, and the governor on the third, saying, will you do this? And, literally it took 30 minutes to answer the question of, sure, just tell us when and where, and we'll do it. And so, I mean, it's not something that happened overnight, Brad, I guess. And by the way, most people don't call me Dr. Gold. Most people call me Jeff, except for my grandchildren, and they call me Grandpa.
Thank you.
Denny, I just wanted to make some points about your comments about the energy sector and the analogy between the two, those two critical sectors. And I don't think it's as black and white as you stated. I'd love to have this conversation in more depth, maybe offline. But there are other critical sectors too that I think serve as good examples. Finance, commercial aviation. Commercial aviation is another one where you have high reliability organization principles. And the irony, I think, is, the health sector, the one that addresses the life safety aspects, is the one with so much grace in it. We have, who knows, 100 to 400,000 preventable deaths per year due to, medical errors. No other critical sector would be allowed that much grace. And part of it is this shroud of medicine that we've, sort of evolved with, I guess, over the last couple thousand years. But I think that there are reliability organization principles that can and should be applied to and within the sector that address, not just the safety, the risk, the reliability, quality, accessibility, affordability, but really, start to pull the shroud away and drive some of the transparency that we probably need in the sector to identify some of the the shortcomings more effectively, more broadly, and fix them.
Dwayne, I'm really glad you said that, because I completely agree with you on that. So I would wonder, in your thoughts and your experience, you and I both know that there are individual delivery systems around the country that internally have been doing the transparency, looking at their own outcomes, their own results, their own utilization rates, and using process and lean management, system engineering, and workflow analysis to try to improve their performances inside. In fact, some of the really best organizations, when I've spoken to them, they're in a very nice position, because they keep looking around to find out who's really better than they are. And if they're lucky, they find somebody who is actually better than some of their other staff, but they're on their own staff. They're just down the hall from them. They begin to learn from each other. How do we magnify that into a county in Arizona? I'm not going to even charge it with the whole nation, but the county in Arizona, in which there are 8 large delivery systems and about 4 million people, 3.5 to 4 million people, who formally, as of today, are still working almost 100% fee for service. And they have tried to band together during this pandemic. But it's safe to say that once they started to work together, for at least 3 to 4 or 5 months, they were actively being obstructed by their own public health people and the governor. And indeed, it's still going on, but since the summer, nobody's paid attention to them. So I'm just wondering what your thoughts would be. How do we congregate a group to try to come together like a NERC or a FERC or an IMPO that would work within the just Maricopa County? I'll leave it at that.
It begs the question, what is the standards development process?
Right.
Right now it's CMS. That's
right.
it.
I agree.
And that's absurd.
Sounds like you and I are in violent agreement. That's right.
I mean, I think the big takeaway from the energy sector is they did it themselves. In the big blackout of 1964, after that, they came together and they established the National Electric Reliability Corporation, which has evolved into the North American, but because it includes parts of Mexico and Canada. But they did it. They didn't wait for Congress. Congress finally, in the Federal Power Act of 2005, mandated a NERC. 50 years later. So what are we waiting for? We need that for. And I sat in these meetings at the beginning of the pandemic, where we had the CEOs of healthcare organizations coming in, looking to Bob and to CDC for answers. And I thought, this is completely backwards. The private sector is the resource. They are the resource provider. They have the innovation. They have the data. It should be the government looking to the private sector for the answers or for the innovation or whatnot. But we don't have that forum. We don't have that process where we can say, hey, here's what we need, figure it out. We can Congress can turn on the money machine to the degree necessary, but for us to have the privilege of practicing medicine, we should have the responsibility for a reliability organization that is capable of operating in blue sky and black sky days.
I agree. Jeff, how do we make that work? Because you've been able to, I think, make that work as among the best that I have seen. However, you do have significant support from some federal agencies that may be a bit immune from political manipulation from day to day or year to year.
Well, I'm not sure about the immunity aspect of it. That does vary from day to day. But at the end of the day, I mean, I agree with both your comments and Dwayne's comments. I mean, the resources, the knowledge, the experience, the ability to collect and share critically important data has got to come from the front line. I mean, you can do all the policy development you want, but it'll never work if you don't have access to the frontline providers of care. And I don't just mean the hospital, but I mean long-term care facilities, et cetera. For instance, we are networked with every single long-term care facility in the state. Every one. We look at their data on case transmission, test rates, all of that stuff, literally every single day of the week to try to maintain an accurate dashboard. I could tell you, literally in 30 seconds, what the occupancy rates are of every single one of our hospitals, how many COVID patients there are, how many are on a vent, et cetera, in literally 30 seconds. And each of the hospitals and clinics and, as does the state, have access to the exact same data. I could tell you exactly where the lines are the longest to get vaccinated and where they're the shortest. And getting into that kind of meaningful data sharing, does take a significant element of trust. Let's face it, let me tell you, I spent 25 years practicing cardiac surgery in New York City, 7 major academic medical centers on Manhattan Island alone. There was not a lot of information sharing, even across the street, let alone across a multi-state region. But, I guess I would say, Denny, that the pandemic has created a crisis of significant magnitude, that it's time to have these conversations on the regional level, and again, on the national level. And, I would, come back to what you and Dwayne said earlier. Believe me, if there are people on either side of the aisle that had the answer to this on the national level, you'd know it. But there is no answer. The answer, I think, has got to occur regionally, organically, and then get melded together on the national level. And what you've been doing in the Maricopa County area, kudos to you, just to get these many tiles together on a Zoom call, on a Thursday afternoon is an achievement in and of itself. My suggestion is to find the lowest possible hanging fruit in areas that people are willing to work together and collaborate, and declare victory on that one piece of low-hanging fruit, and then go on to the next one. And this is not about, we work with multiple different competitive healthcare systems here in the state of Nebraska, although it's a pretty rural state, as you probably know. There's no shortage of competition for market share in our community. But when it comes to health security, let's just say people are completely open and transparent about supplies, personnel, open beds, you name it. We've got a really, really well-functioning, trusted system. And by the way, it's not run by the state or the federal government. It's run completely locally. It's actually, interestingly, the university has essentially become the trusted partner. Even though we operate a large academic medical center, it's the university and our College of Public Health and the GCHS, the Global Center, has become the trusted convener and the trusted partner of doing this. I mean, it's not a corporate structure. It's not a nationally recognized organization, but whatever it is the convener and it is the trusted partner. And it certainly is the trusted partner for interpretation of the science. I mean, we convene multiple times a week the directors of every local public health department, every single healthcare coalition, the state and a multi-state region, twice a week for an hour, and go through the core data for our region, things we need to be concerned about, common challenges and opportunities, et cetera, up to and including the governor himself, of the governors, every single week. I mean, it's really quite an amazing system.
I just want to point out, there has to be the forum, the governance structure, there has to be the portal with the information digital exchange model. And, we can kick it to Jameson or Tom Wilkinson, but because you have healthcare organizations that are scatter plots across the nation, they're not jurisdictional by county, state, whatsoever. If you look at Kaiser, HCA, United Health Group, whatever, those are scatter plots. And if you want the information for an outbreak for a county or whatsoever, from a public health standpoint, you have to be able to exchange that data through some marketplace.
You want to talk a little bit more about that, Dwayne, in terms of, some of your thoughts about, I think it's the merit and the merit, if I'm remembering that correctly.
Yeah, and Jameson or Tom, if you guys want, or Eva, you guys have been sort of on this journey with the medical public health information sharing environment and the mix, the medical exchange model. But I think when you look at like cyber currency as another example, another sector for analogous examples, you've got the non-fungible tokens, Bitcoin, Ethereum, and whatnot. We have a way, to capture and package medical data. My medical data could be a MEDIT, the medical digital information token that I can put in the marketplace, with my DNA or medical problems or whatever, and now it becomes of value that I can exchange for health insurance or healthcare or whatnot. Or I, as a healthcare worker, can earn merits, medical reliability information tokens, when I participate in the standards development process or continuing medical educations. And this is a way, I think, to get the associations buy-in, AMA or ASAP or AAM or whatever, where my membership in as staff on a hospital and as in a professional association or society confers me membership into the NERC. And with that, I have a responsibility to participate in, or I can do, we can do national credentialing and licensing kinds of things. But you can earn merits by participating in the governance process, which forces, if you're going to develop a standard, you got to know the latest, greatest, and so you're constantly developing professionally as part of the process.
Eva, I think you wanted to weigh in on the conversation.
Thank you. So I think, a lot of the comments about private sector and federal or like how it works together, it's kind of an interesting discussion, because I started out working with private sectors. And I have to say they are really quite efficient when it comes to making changes that they could see definitely provide better service and everything. So I think like that's one of the challenge in healthcare. I think Dwayne nails it. It's the data, or like I think all of you say, who owns the data to begin with, right? If we say we are going to say somebody owns the data, so patient has no access to all their medical record. So even themselves cannot get everything from the doctor. So how could we really say we're going to transfer it, like share data, when there's no ownership, a clear ownership of who owns what? And there is I think that's a big hurdle. I think it's interesting about Arizona and Nebraska, the two contrasts of things. But at the end of the day, I think public health truly is systems. Public health truly shows that it is really a systems approach that cannot miss out anything, right? So you can see transportation, they can really do a lot of great things in the private sector, and then government comes in and do some regulations, but the sectors themselves truly march forward. So in the same way as aviation, right, they have a lot of the standardizations, and then government comes in with the standards, but even that, the data is not totally shared, although it's like if the government wants data, they will be able to get it, and for safety reasons, absolutely, they will be able to get it. But privacy of data of individuals, you won't get it, even for about civilians, right? So that's what we see in the of the contact tracing. So I think there's like the bottleneck. I think healthcare itself is quite different because there's a lot of like what we say is the private or personal health information that because under HIPAA, it cannot be shared as easily as other type of data. But I still think the ownership has to be well defined, and that then we can talk about, I think the tokens or like giving, ownership of those data, and that citizens can actually contribute to those data. When you actually get to that level, that is the power, because then individuals can actually really provide those information, and that they have the ability to provide those information. And I think at the moment, no patient has that capability, and that creates an extraordinary big bottleneck already. And then of course, private sector has some, and then public also the government also have some. So I think we're talking about a host of problem, but nonetheless, I think I think the data ownership itself is an issue, and that we have to address. And my feeling is that, I think, as Dwayne said, that if there is a token that provide that people can submit data and that they get merits back that count towards insurance or medical care and everything, then I think you're talking about a life system where the a lot of the people that have the capability to contribute will be able to march the system forward. Then the government could just be like, yeah, okay, whether you want to participate or not, the rest is going to move forward. And I think the government would just have to go along at that time.
I think you make an excellent point, Eva, too, in terms of, we forget the patient sometimes. I mean, we're focused on the patient, but we forget the patient in terms of the role that they might be able to play in pushing some of this. I'm curious as to, Dwayne, you made a comment about, starting somewhere. And I think about, some of the silver linings during the pandemic has been the level of private sector collaboration. They have come together, even, competing healthcare systems, competing manufacturers working together with a provider to create a new design, et cetera. We've seen this. I do believe that success can beget success. Are there areas that you or anybody on the call would suggest as a place that we might start to prove out that you truly could have some kind of enabling structure as opposed to restricting structure from the government, but that would allow the private sector to, we've proven healthcare can move fast. We can innovate, we can collaborate. Hopefully we can do that even when we're not in the midst of a crisis. Do people have ideas on where we might start with something that we could be successful at, that we could prove those who might be naysayers?
So MITRE, I'll put the link up. But MITRE has a COVID-19 healthcare coalition that they started. It was, again, voluntary basis, no reimbursement for services. They've now, they now acknowledge that it is beyond, it's past the time where services should be volunteered to this coalition, and it needs to move to whatever next stage that might be. And I talked with Jay Schnitzer, who's the chair of that effort, early on about this and the NERC concept, and if this could be maybe the nugget or kernel on which to sort of grab on when at the right time, and get the, there are over 1,000 private sector corporations, including some of the biggest IT companies in the world, but some Fortune 50 companies, academic centers and whatnot. But it might be a start. They've got a list of over 1,000 private sector companies who are interested in working together for the COVID-19 pandemic. So there's this medical bend to start with.
Karen, I would say some of the low-hanging fruit is data sharing. It's one of the least expensive things to do. It builds trust, and one just needs to sort of get over, what you're willing to share, how you're willing to share it, who'll take the responsibility for it, how it's collected, et cetera. And the shared data becomes powerful. I mean, there are many other things that can be done in workforce development, supply chain management. You know, for instance, if you're familiar with the model in St. Louis of the collaborative system that's been set up under BJC, which is, you know, pretty successful. But there are multiple different regional collaborative models that have attempted to either save money, improve quality, change access, things along those lines. But at the end of the day, you know, data sharing, I think, is a pretty good place to start, particularly, you know, where we are, all things pandemic right now. It will definitely save lives.
You know, and I think we could perhaps start in a place that, you know, might be not quite as sensitive as, you know, when we get into outcomes, so many questions, lots of sensitivity around it. We certainly saw in, you know, in urban areas like St. Louis, like Chicago, et cetera, where you had a number of medical centers or delivery organizations, at least sharing data on their patient census, their anticipated, their product.
Yeah, so, you know, let me, if you don't mind, I'm just going to very, very briefly share the screen just for a minute, if that's okay.
Absolutely.
So this is the daily dashboard that the university publishes and scrapes the data every day from the entire state. So what you're looking at here, for instance, this is all things COVID, but cases, test positivity, deaths, hospital beds, ICU beds, ventilators, all the real-time immunization status. And this is the actual metric, and this is the per 100,000, and this is the so-called R0, or reproduction velocity rate, for each of these parameters. These are the parameters for hospital acuity, and these are the so-called aggregated indices that look at trends. And this is broken down for every single local public health department, every single one of the healthcare coalitions. This is the digital format of it. If you want to just look at the trends, you can get a feeling for, this goes back to the beginning of time or about a year ago. But if you want to look at the last month, for instance, this is what the last couple of weeks looks like. And again, you can slice and dice this, you know, any way you want to. If you want to look at the R0 values, these are the R0 values. So for instance, you can see there's definitely a change in transmission rate over the last 10 days here. This would be statewide. This is, you're looking at Nebraska at the moment. But for instance, if you just wanted to look at Douglas County, which is where Omaha is, or if you even wanted to get down to the individual hospital level, you could do that. I mean, this data is just incredibly powerful. And this is compiled on an every 24-hour basis. So the data that I just showed you is through midnight last night. I mean, without that, we would be really, really strapped to be able to deal with the, you know, variability and in local communities' needs. For instance, and turns out, you know, you've all read about meatpacking, right? Well, it turns out the hospital systems and the outpatient facilities in the communities where the meatpacking plants are don't have anywhere near the capacity to deal with the medical issues, the testing, the vaccination, the hospitalization, et cetera, that's necessary. And therefore, having data about where there's capacity to transport patients, where there's supplies, what the acuity is in any ICU across the region becomes incredibly powerful. So again, this comes back to the idea of data is everything.
And I think you make a very good point, because one of the questions that came up in our session last week was somebody in the audience had asked about, you know, how do we operationalize some of the models that every single hospital had to create in order to report on their anticipated patient demand, their availability of supplies, et cetera. I mean, that was just a small piece of the puzzle, but they had to build things. They built them on the fly in many cases. And it's, how do we take the work that the Healthcare Coalition that Dwayne mentioned earlier, they built some interesting models, this kind of model, some of the work that every hospital has done, and, you know, how do we build on what we've already built, as opposed to going back to, you know, square one when we're all over and then we suddenly get surprised.
Yeah, you know, the other aspect to this, I think, is understanding not just the role, but the capability of public health public health offices. And, you know, in the role of advising what to do, there's this huge gap between putting out recommendations and then actually, you know, implementing those recommendations, either at the community level or within the private sector, within corporate America, or, you know, small or large businesses. And I think that there is a huge gap and a niche for you know, a private sector component for public health. Like, you know, I mean, I think of Charity Dean and the public health company, a startup that she's doing, where, you know, we've got industries like the aviation, commercial aviation, or the cruise line industry, that, or, you know, all of sports and entertainment, that are trying to reopen, and they're trying to do it in a responsible way and implement local or state or federal public health recommendations, but could use, you know, more effective guidance in doing that. And that's a huge part of reopening the community safely, but reopening nationwide, you know, getting the economy back up and running.
You know, I hate to be the bearer of bad news, because we only have about 3 minutes left and a little bit of housekeeping. This is clearly a conversation that should continue. And hopefully that, you know, we'll be able to continue part of it by the creation and the dissemination of the white paper on this work. But, you know, I would hope that that others would join us and in continuing to think through these things. And in terms of looking at, you know, other sectors as well, because you mentioned public health. Obviously, public health plays a role, but there's so many different sectors. You think about, I've looked a lot at like vaccine distribution, for example, and those states that have relied on the public health departments to do it, they've got the clinical expertise, but not the supply chain and the logistical expertise, for example. So how do we have all of those parties at the table, and we start looking at things from multiple perspectives and making a difference? So I want to thank you, Dr. Caneva, you, Dr. Gold, for and Dr. Cortese, for getting us started on this journey, and we're just getting started. I also want to say thank you to CAPS Research, and if I might quickly share the screen briefly, CAPS Research has a tremendous amount of resources. And I think about some of the issues that, you know, how can we learn from others? We're not the only ones who have been dealing with challenges during this pandemic, and there's innovation in other sectors. Perhaps that's also a role where the government could at least help start connecting some of these. Brian, we've just got a minute left. I so apologize, but perhaps you could just say a few words about CAPS Research and close us out.
Yeah, sure. Thanks, Karen. And some of you may have heard during the opening on the first event, and then even last week. So CAPS Research is a partnership between ASU and the Institute of Supply Management. We are focused on supply management research, very forward-looking concepts. How do you address sustainability, risk in your supply chain? How do you ensure that your supply management practices look end to end? I sometimes say cradle to grave and then back again. And so this is, I've recently taken over for CAPS Research from being a CPO at MasterCard. And this is my first time working with the McKenna Lecture Group. And it has been a great experience. So Karen, Jean, Denny, Mike, thank you very much. Dick, thank you very much. It has been fun. And I look forward to staying engaged, both because I think the healthcare sector and CAPS will continue to work on papers and research, and look forward to working with Jean on that. So again, Karen, thank you very much.
Thank you. And thank you too for everybody's participation. I hope this is just the beginning of the conversation, and we look forward to creating and sharing the white paper and getting your response as well. Thank you again, everybody, for your very valuable time and contributions.